Now let's start to talk a little bit more about what your specific approaches might be within this team. First, as we said, let's review who would be there. Medical professionals, police, and community assets, including families, neighborhood resources, and professionals. And neighborhood resources includes informal connections such as neighbors and landlords or other people who are tenants or roommates. Anybody really who's willing to be a part of a team and know the individual and care about the individual. What are we working towards? Well, we're really working towards doing two things. One of them is developing a crisis intervention plan, and the other is a proactive plan. A crisis intervention plan simply means that we are going to plan ahead for the next time an individual is in crisis. Some of the things that we want to think about in that plan are how can we specifically support that person in the midst of a crisis. And for that set of strategies, you need to go back to Module 4 and look at the strategies we learned in the arousal cycle. And there is a link there showing you a sample of a crisis intervention plan. Now that sample is a very elaborate sample done by myself. This is a fictionalized one, but it's based on real cases. You are not going to need to do anything nearly as sophisticated as that to become effective for an individual. Think about the things that set that person off, the triggers, in other words. Think about what their behaviors look like. Think about the responses that tend to work and write them down. That's a crisis intervention plan. Think about who are the contact people, whether there's medication that needs to be given, that sort of thing, and write that into the plan as well. This plan can be revised and should be revised every time a person has another crisis, another event, so that it is as current and effective as possible. The proactive plan is simply a plan that helps us to progressively, gradually, and systematically improve a person's overall quality of life. In other words, we're no longer just reacting to crisis, we're trying to find ways to help an individual to improve their mental health and their quality of life, but gradually reducing the amount of crisis-related behavior and replacing it with skills that are going to be functional and effective for that person. So for example, if an individual is going into crisis without recognizing the signs and symptoms, one of the things I would do in a proactive strategy is work with a person at journaling or monitoring their own behavior, staying connected to somebody who is a regular part of their life, and letting others help them to monitor their condition. Learning how to use PRN medication, or being involved in a range of healthy social and psychological activities so that the person has balance in their life and maintains good mental health. Helping to maintain their physical health, helping to make sure they have their income needs met and their housing needs met. All of these things are part of a person's proactive strategy, and that's just some of the things that we can do. Why? Well, the idea here is that our team will offer approaches that are compatible with each other instead of being, as we said before, at odds or having gaps in our services. This will mean that people will be less likely to be a frequent flyer. And I'm not a big fan of that term. I've only used it because I know that some people will be more familiar with it. It means that the consumer will be healthier and safer, and so will the community as a result of that person not being out there being disruptive. We will use the resources that we have the most effective way possible. And we all know that resources sometimes are limited, so we do need to be very, very efficient in using them. There'll be less time wasted in that person's life in crisis. In other words, usually even if they are in a crisis, it will be less severe and shorter in duration. We're more likely to assign the correct services to people, and there's no lost knowledge when people leave that individual's support circle. If somebody passes away or transfers out, then others within that team can welcome a new member and bring them up to date, instead of losing all that social capital and knowledge every single time somebody has a transition in their life. How do we do it? Well, if a person is receiving services from a community care provider, such as a group home, a day program, potentially even the school, or a one-to-one worker, then the community care agency should be the ones that are asked to lead that process. If the person receives none of those services, there are really two choices. Choice number one is for the family to play a lead role and be a facilitator, or to find somebody else that's an associate that's willing to do it. Or choice number two is to speak to a social worker if one is available and look for the possibility that some sort of services can be provided. and make it clear that one of the things you're hoping for is that that service provider would help to facilitate a team. They're going to not work on their own in the team. The community care agency is going to get input from other community care agencies if there's more than one, and from medical community professionals and police, including people, for example, when we go back to medical professionals, such as BC Ambulance or first responders from the fire department, anybody that's having regular interactions. The police or the emergency department can actually ask the community care provider to work on this, because the community care provider in some cases is well aware that this is a possibility, and to be honest with you, in other cases is not aware at all. There is a very significant range in the models of care, the sophistication of the services that are being provided, and not everybody that's out there doing this work fully understands that this is part of what they're being asked to do. We can also involve, as we said, the social workers from the Ministry for Children and Families or from Community Living BC if it's an individual who is an adult with a developmental disability, the school if the person is school age, as we've spoken of, or any local agency from whom they're receiving care, including First Nations agencies, drug and alcohol agencies, and even informal social groups such as Scouts, Boys and Girls Club, that sort of thing. If there's a healthy connection there, see if you can build upon it. When should this be done? Well, as we said in the previous slide, we do this for people after it's been established that there is a likelihood or potential that they will cyclically end up being in crisis. So as a general rule, we do not do it after there's been only one incident or if there's only one incident every few years. Typically, we look at a barometer such as a second occurrence occurring somewhere between 6 and 12 months, and we're also considering the severity of that occurrence. If it's a very significant event, we might do it after one time. If it's a very minor event, we might not do it till the third time. Some of the things that we're looking for that would trigger this include elopement, which remember means running away. Self-injurious behavior, that could be, for example, things like biting themselves, hitting themselves, or what we call self-mutilation once again, which is where people usually do things like cut themselves but then hide the injuries. Any type of aggression to people or valuable property, any attempt at suicide or any obvious ideations of suicide, overdoses, any of those sorts of things would be crisis occurrences, and they're the sorts of things where we would, after a second one especially, want to amass a team and start working on the crisis intervention plan and a proactive plan. And we should review those plans at least once a year, or, and particularly for the crisis intervention plan, after any major crisis occurs. So what's the first responder's role in these team supports? Well, one of the things that they can do very simply is be an advocate for the creation of a team. And the crisis can be the impetus for a team coming into play. So the advocate, the first responder, can simply say to community professionals or families, why don't you get that started? I'm willing to participate if you're capable of doing that, and contribute what they can. But most of all, it's about saying to somebody who's in a position to begin this team that it's important that it happen instead of just repeating the same crisis over and over again. This does not need to be a time-intensive or even a sustained role for the first responder. The first responder can gradually evolve out of needing to be on this team as a person's behavior or mental health improves. There'll be fewer crises and less need for police intervention. So the idea is that we're going to leverage the limited time we have, invest it where it really is more likely to pay a dividend, and gradually reduce our involvement if we wish to, because sometimes we don't want to, as we can. The other thing a first responder can do is be an information distributor. As I said earlier, often social workers, family members don't know the full story of what's going on in the community. The consumer may be embarrassed or worried that they're going to be in trouble and may not share that information fully with others in their support circle. So it's very important for the first responder to keep people in the loop. And I would say we have to make sure we don't assume that person A is going to communicate with person B. While I know it can take some more time, I think it's important for us to make that phone call directly to the parent, directly to the social worker, directly to the school, especially in the early going. And then we kind of can get the ball rolling on this team. So while we aren't the ones creating the team, It's our information and advocacy as first responders that can sometimes create that impetus. We also want to build relationship with the individual. If we only are showing up when that individual is in crisis, we're probably not going to be surprised that they're not happy to see us or that they associate us with negative feelings and negative events. Instead, we want to try and spend some time with that person, even if it's limited, on a proactive basis. Go and see that person for a few moments at their school or in their local coffee shop or wherever you know they hang out. And even if you only spend 3 or 4 minutes with that person over a number of little visits, you're going to go a lot further. And one of the most simple things that I say to people is if you're willing to invest in something as simple as some Tim Hortons coffee or the occasional package of cigarettes and share those things with people, especially street-involved people. Obviously, we're not talking about youth here, but street-involved people, often that's a simple way to connect with somebody. It gets the conversation started. We can also help with referral and connection. So when we have, as first responders, particularly police, decisions to make about whether or not to treat a person as an individual who we're going to recommend a charge for, or whether we're going to try and divert that person, don't forget about approaches such as restorative justice here in Mission. This program, in my opinion, and in the opinion of the city, is vastly underused, and we really can use it in a variety of innovative ways. For example, let's say an individual is in conflict with a neighbor, a family member, or a landlord. That is an exact scenario where restorative justice can be useful. It's not just for youth who are in trouble, and that's too often where we're seeing those referrals coming. It's really for any time people are having ongoing conflicts and have to find a way to mend fences. Also, don't forget about the Aboriginal justice approaches and utilize those to help a person get back on track. We can often do things in informal ways with families and get them involved, setting clear expectations with families and asking them to follow up. And that's obviously a first step in many cases, but if we're not crystal clear with people about what we expect from them, then families are often at a loss to try and follow up with that individual. Another thing that we want to think about, and it's not on this slide, and it should be because it's of critical importance, is that people will often have a connection with the police and will not need to be taken to a hospital or a social service agency, but they will not know exactly where to go. And we are going to, through Community Cares, distribute some RAC cards, some simple cards that we hope police officers and firefighters and ambulance people and schools and churches can have on supply and hand out readily to people. But if you don't have that information, the simplest thing for you is to make sure that you connect the person with the crisis line in your area. And I'll put up a link about the crisis line that accesses for Mission. Even if the person's not suicidal, the crisis line is still a good call because the crisis line is a quick referral. They can tell a person about the services in their area, they can connect them with mental health staff, they can tell them or arrange for them to find ways to get to medical facilities for ongoing care. So the crisis line is a brilliant place to start. Finally here, don't forget to have a connection with landlords, because one of the things we hear from landlords is that they're okay with taking in tenants who have developmental challenges, mental health challenges, or social skills issues, as long as they know they're going to have supports. And we're going to talk about how family and other neighbors can play a role as well. But for that police officer, keeping connected to a landlord is a way to make that landlord feel more secure in the fact that that individual can stay in that home. Therefore, they don't become as quickly, don't likely end up on the street. And also, the landlord can be a conduit of information. They can let the RCMP know if they're seeing issues or concerns that suggest maybe a person is decompensating or escalating and becoming potentially a hazard to themselves or others. And the police officer, after doing this relationship building, after making connections with family and landlords, can simply monitor and check in. It's been my pleasure to have the opportunity to go out with some members on ride-alongs. And while I know that on some watches you are constantly hopping and having to go from one crisis to the other, there are other times, particularly on day shifts, where the world tends to slow down a little bit, and you may have an opportunity to interact with an individual during those types of opportunities, just driving along and seeing them outside the Tim Hortons, or perhaps you see them when you go for your meal break, your 10-6-2, and you can take a moment to actually just connect with that person, check in and see how they're doing, give a little bit of encouragement and praise. Most of the first responders that I know are very good at that and very happy to do that, and I think it's an excellent habit to get into. What is the role of other people? Well, the social worker's job, and many people don't know this, is to be a coordinator and facilitator. They are really the people who are in the business of connecting a consumer with the services and the supports that are going to most help them in the community, and to help people be coordinated and connected to each other. So if there isn't a community agency providing services for a person, the social worker is a logical place to go, and that's really one of the things that we can ask them to do. Can you help us to stay connected? Can you help us to find a service for somebody? The reality for social workers is that it's not always easy to find those services, and so it sometimes is going to take some creativity. It's going to sometimes take some patience from others within that circle of support. What about community medical professionals? Well, we're looking for those folks to help out with more than medications. We want them to connect up with psychosocial rehabilitation providers, such as group homes, day programs, mental health workers, outreach workers, counselors, schools, and other educators, just to name a few. Consider the community data that you get. In other words, doctors should be asking the consumers they're supporting if it's okay to connect up with other people in their community, or even to come in the door with some of those people, because they often are going to get a more full picture about that individual's progress, how well certain treatments or medications are working, by talking to people other than the consumer themselves. If possible, we want to try and coordinate processes such as medication titration with non-medical supports. Too many times I've seen people going through dramatic medication changes who have not had an opportunity to prepare in their housing or their work or their relationships, and a result of that has been that they've had a major breakdown someplace else and the system fails. Even though the medication change in and of itself might have been a very positive change, given the fact that during the actual flux of that change, the person had some major disruptions in their housing or their job, for example, often the medication change was doomed to fail. So it's just a really important thing for us to make sure that we time medication changes along with other social supports. It's important for us to bolster social supports when we go through medication changes. And it's important for us sometimes to delay them. I know that it can be tempting to change medications more quickly, but it's important sometimes to delay them or slow them down in order to accommodate other changes that may be occurring in a person's life. And the school can play a role not just inside of its own walls. Many schools have school-based teams, and the ones that don't, in my opinion, should. School-based teams are informal but valuable teams that usually are comprised of the principal, the classroom teacher for an individual, the learning assistants or resource teacher if there is one in the school system, and there normally is, and they may have an occasional visit from other psychosocial staff within the district, including the educational psychologist, a youth worker, counselors, and so forth. The family can be involved if that's possible, especially after the initial conversations have occurred and we realize that we do need to provide a support. And we may even involve some unique other supports, such as coaches or peer counselors or outside community tutors or community-based professionals. So we want to make sure that we're all communicating with each other, and this includes teachers and the educational assistants or EAs. Keep everybody in the loop. And don't wait for crisis to occur before we start to keep each other aware of what's working and what's not working. So we want to work with these liaison workers within the community and within the school-based team itself before crisis occurs, so that we have a connection between, especially when a student is in middle or high school, all the different classroom teachers, all of the other people in that school who are working with that individual, and the outside world. And so we have to identify one person within that team to serve as a bit of a liaison. Often it's a counselor, a principal, or a learning assistance teacher, but it doesn't really matter as long as it's somebody who's committed and has a connection to that individual. The cultural community can also play a valuable role. Does a person come from a culture that is well represented in your community? For example, in Mission, First Nations community is well represented, and so is the South Asian community. And it's very important for us to think about that community group as a resource for people's mental health, because that's why we all get involved with community groups, because it helps us to maintain a social connection, and that helps us to remain psychologically and physically healthy. So people in that cultural community may play a simple role in terms of translation. They may also help us to understand a family or consumer's values and why they may be reluctant or hesitant to take care. They might play a role as an advocate for that family or advocating to the family about care. There may be a liaison to the family there so that the rest of the team is able to communicate back to the family through this individual. There may be a connection not only to culture, but to possible faith-based services. And I don't know if people know this or not, but many ministers, pastors, and other clergy people are trained as counselors or have other psychosocial backgrounds. And so often they can play a valuable role in not only helping a person to stay connected to their spirituality, which, as we said, is valuable as well, but also they may be able to help do some actual service delivery, help a person to have somebody to speak to in a therapeutic way. And of course, connecting people with their culture can be a big source of pride and help an individual to have a positive identity, which, as we've talked about, is an underpinning of good mental health. And think about the variety of community professionals that exist out there. So your job, if you're a community professional working in something like a group home, a day program, an outreach program, a life skills worker program, a daycare, a mental health worker, anything where you're working with individuals in a community setting, part of your job is to help orient the police, fire, ambulance, and schools to what you do, so that they have a realistic understanding of what you can be expected to do and where they need to fill the gaps. It may be also important for you to describe to them the policy where you work and the philosophy of where you work before a crisis occurs. For example, I've been in situations where the police were surprised that I was not able to put a person into tie-downs or restraints. And so it would have been useful for us to clarify that from the beginning, because we had 2 or 3 interactions with these police officers where they were kind of becoming bitter towards us, wondering why we hadn't done more to control an individual's behavior and why we were calling them. We may also, as we said earlier, play the lead role in developing crisis intervention plans and proactive strategies. And as we do that work, it's our job to seek input from team members. Sorry about the spelling error there. It says fro, but it should say from. So we want to make sure that we're doing our best to seek input from everybody else in that person's circle of support or community-based team. And what's the role of the family? Well, the family needs to be thought of as our client. This is an interesting change in the way some of us have been trained. But remember, if a person's family does not have much faith in the individuals who are supporting their child, then they're going to often undermine that work. They're going to often communicate with the child that they don't trust the people who are involved, and they're not going to be very likely to support those procedures actively and participate actively in what they're doing. So we have to keep the family happy as well as the consumer. Now there is, as I said, an exception to this, where, for example, there's been a history of trauma or abuse between a family and a consumer. We're normally going to just respect the consumer's right to stay away from their family, at least until such time as that individual thinks they might want to have some reconciliation. But we're not going to force or push that issue. If the person's family is a willing participant, we want to get them involved as much as we possibly can. Keep them as comfortable, happy, positive, and not overwhelmed as we can, so that we can have that person be involved, those people be involved in the support of their sibling or their child or their spouse. And remember, we're not just talking about parents here. So we also know that families are the strongest advocates and supporters for the people we have in our care. Nobody has been with that individual for as long, nor will there be anybody who's with them as long. Nobody knows them as well, and nobody has a more pure interest in advocating for that person. So families are often our most persistent and effective advocates. Sometimes they're not terribly effective, because sometimes they are advocating from a position of anger or bitterness disappointment, or hopelessness. As community professionals, or even as community volunteers, we need to take a step back and realize how challenging it can be for families to do this advocacy work. They have often been frustrated, often been disappointed, often been let down, or had promises broken. And so if a person is communicating with you in a way that doesn't strike you as being really accessible or friendly, do your best to rationally detach from that and listen to the message behind the advocacy. Be as responsive as you can to the message and respectful to the individual, even if the way the message is delivered can sometimes be challenging. Do not expect professionalism from non-professionals. And the rule is this: the more unprofessional somebody else is being, the more professional that you as a professional need to be. So when a family member is losing their cool, it means you need to be more attentive to keeping your cool. That person is expressing that they're frustrated and upset, and they have had to deal with downstream issues as a supporter of a person with mental health needs for usually a very long time. They're not trained. Sometimes it's the first time for the person, and they're often dealing with multiple stresses. As we said, it's often their first time experience. The system can be very confusing to that layperson, and as a person becomes stressed, it becomes even more baffling. So remember, that family is as stressed as many times as the consumer is. So families need to be informed, and they need to play a role as advocates, and they need to ask for the guidance that they want. They must be sustained in their connection to their family member, and we need to maintain what we're doing to help them as well. We need to sustain the provision of information and our alignment with them as advocates and guides. Lastly, but perhaps most importantly, is the role of the consumer in the team. The consumer has a responsibility, and that is to get better as quickly as possible. Now, quickly as possible, as we've spoken of before, needs to be differentiated from fast. Sometimes a person's speed is not going to be fast by any definition, but we want that person to be contributing as much as they can to their own self-care so that there is no wasted time, no wasted months or weeks. This is rarely a fast or direct process, but we need to expect that a person may go through some relapses or recidivism. In other words, they may step backwards, I should say, or regress. And we need to support people after they've had these slips. In fact, we need to be realistic about the idea that slips not only are part of a person going forward, but we need to measure whether or not those slips are slowing down, whether their intensity is reduced, whether their duration is reduced, and see that as signs of progress. If we're not successful in supporting an individual, it is not their job to accept responsibility for that. It's our job as professionals to accept responsibility. And this is something that really strains a lot of us as professionals. Because, for example, I've spoken to teams who said, well, that's not true because Michael chose not to do the program that we put in place. The answer to that is, as staff people, it was our job to adjust the program so that Michael would want to follow it, to establish relationships that would allow him to trust us enough to follow it, to communicate clearly enough with him so that he understood it enough to follow it. So we need to be looking always at why we did not succeed in getting that person forward. This is not the same as blaming ourselves or allowing others to blame us and try to get us in trouble. That's not constructive. We're not looking to find people to bear the burden of blame. We're simply looking to address why something isn't working and adjust it. And that's extremely important. So we're always going to use a model, and you'll hear me say it multiple times throughout this course, of assess and address and review. So we always assess what an individual needs, try to address by tailoring the supports to those needs, and review because even if we've done a good job of assessing and addressing, constantly need to be reviewing things because people's needs change and evolve.